Access at PFC. During the webinar, you may send questions throughout the presentation in the chat feature or in the Q&A box. And just as a reminder, and as a thank you for being here tonight, we are offering a $99 new patient assessment that includes a consultation and ultrasound if needed, and that is offered to patients without insurance coverage. With that said, I will pass the microphone over to Dr. Strug.
Okay. Well, hello and welcome to Pacific Fertility Center. My name is Mike Strug. I recently joined the clinic in September of last year, so I'm super stoked to be joining this fantastic group. And as far as my background, I grew up on the East Coast, actually in New Jersey, and have slowly been working my way west as I went through my medical training. I trained for medical school and did graduate school for a PhD at Michigan State University and stayed there actually to complete my obstetrics and gynecology residency, and then moved to Stanford for my fellowship in reproductive endocrinology and infertility. And at that point, sort of fell in love with the Bay Area and have decided to stay here at least for the next immediate future. So, and now, sort of to move into the agenda for tonight, I want to start by talking about why patients should consider freezing eggs and embryos, and mostly a discussion surrounding the impact of age on fertility. And so that's a really important discussion. And then just, are there ways we can predict fertility, discussing the egg freezing process itself, success rates using frozen eggs, and also I'll field some questions from the audience. So first, why should we be considering freezing eggs? And part of it has to do with people are prioritizing working and their careers over fertility. And this has been rising as time has been going on, and that's what this graph shows. And so it as a consequence of that, even though it's wonderful that people are prioritizing their careers over fertility, the effects of fertility, or I should say age on fertility, are still apparent. And this diagram shows the age at which patients are selecting to start building a family. The other thing I want to mention is that a lot of these diagrams and data use terminology such as women, but we understand that not everybody identifies as a woman. So just want to give that little disclaimer up front. But for the sake of this presentation, when I refer to women, I'm mostly referring to those who are assigned female at birth. So this is a graphic that shows fertility. So folks who have never tried to get pregnant before and are now trying to get pregnant, and looking at the likelihood that they will conceive within 2 years based off of age. And unfortunately, we see that as one ages, there's a decline in fertility. And starting at around 40, the chances of a live birth per month are unfortunately only 5% or less. And this has a lot to do with the effects of age on ovaries. And this is something that not anyone really has control over. And that's what I try to sort of convey to my patients, that as a part of the normal aging process, the ovaries were designed in such a way that there's the total number of eggs that you will always have at birth. And as you get older, the number of eggs will decline. And starting in your 30s and certainly your mid 30s, we see a sharper decline in the number of eggs. And by the time folks reach menopause, there's very few eggs left, but there are still some eggs that are present there. One of the more almost important concepts beyond the number of eggs declining with ovary or with age is also important to think about the genetics of the eggs as one ages. And there's just a higher likelihood of having chromosomal or genetic changes in the embryos that are produced as one ages. So as you grow older, there's a higher likelihood that as the genetics are passed down from an egg to make an embryo, that there's an imbalance in the genetics, and that results in reasons why the embryo will either not implant, which is infertility, or an opportunity, unfortunately, where it might implant, but it will stop growing because it's just not a healthy, viable pregnancy as a result of those imbalances in the genetics, and that would be a miscarriage. This is what I'm referring to when I say the imbalances in genetics. So most people have a balance of 46 chromosomes, which is referred to as euploid or just balanced ploidy. And so there's 23 chromosomes and two copies of each of those. In the setting of imbalances, this is referred to as aneuploidy, where you can have an extra copy of one chromosome, and this is trisomy 21 or Down syndrome, which is one of the few scenarios where having an extra chromosome can be compatible with life, but there are some health implications to that. And most circumstances where there's an extra or a missing chromosome, that will result in either the embryo not implanting or a miscarriage, an early pregnancy loss. So we can actually test embryos with to evaluate whether they have balanced or imbalanced genetics. And so this was a study where they looked at embryos and correlated based on age what's the likelihood that the embryos were aneuploid or imbalanced. And similar to a decline in fertility that's associated with age, we see a rise in aneuploidy or imbalances in the genetics. And that rise tends to occur more commonly in at a sharper rate starting in the mid 30s. And certainly by the time you reach your 40s, this becomes really prevalent. And unfortunately, most of the embryos that are being made in this age group tend to be genetically imbalanced or aneuploid, contributing to the fertility problems that these patients often see. And so the concept behind egg freezing is that if you freeze your eggs here in these earlier time points where your eggs are predicted to have lower rates, never zero. So there's even at the age at your like peak fertility, we see almost a third of embryos are abnormal. And that's important to know because a lot of folks wonder why they don't just get pregnant when they're trying after 1 month of trying or even 2 months. And the reason is because even when you're your peak fertility, a certain percentage of embryos are going to be genetically imbalanced. And so that's why it takes several months sometimes to be able to conceive. And so the concept behind egg freezing is that you freeze your eggs at one of these time points, and the uterus, although it does age, and the uterus is what holds a pregnancy, does age to a certain extent, but it doesn't age at the same rate as the ovaries do. And so when you actually go to use these eggs to create embryos, they retain the same likelihood of developing an embryo that's aneuploid as the age when the eggs were frozen rather than the age when you actually go to use them. So let's say you froze your eggs at 28 and then you go to use them at 42, the likelihood of those chromosomal imbalances are going to be based on the risk of when you actually froze them. So how do we actually predict fertility? So there's different measures. One is predicting egg quantity, and the other is egg quality. And I sort of alluded to both of these when I was going through the impact of age on ovaries and eggs specifically. When we're referring to evaluating egg quantity, there's a blood test called an anti-Müllerian hormone. And that's a blood test. All it does is it gives us a rough estimate of the number of eggs that we anticipate to be present because this hormone is produced by the little cells that surround the eggs. And so the more little eggs there are, the more little cells there are making this hormone. And so the levels are higher. In antral follicle counts, that's an ultrasound where we're actually looking at the ovaries and looking at the follicles, the little circles within the ovaries. And I'll show a picture of that in the next slide, but we can count those follicles. Each month, the ovaries recruit a cohort of eggs called the antral follicles. And out of those eggs, one of them will grow to become an egg that can be ovulated potentially for a pregnancy. But even if somebody's not trying to get pregnant and you're not on any form of like contraception or anything like that that would suppress the eggs from growing, we would see the egg grow, ovulate, and it can result in a pregnancy or not. And then the whole process starts over again. And actually, those other follicles that were recruited, in addition to the one that actually ended up being ovulated, all of those will just dissolve off. And unfortunately, that's why one's egg numbers decline with age, because there's a cohort of eggs that are recruited each month. And that actually happens even if you are on birth control pills, which suppress the ovaries from growing eggs. So the ovaries are just growing follicles each month, regardless of whether you're on birth control or not. As far as the predictors of egg quality, age is really the best predictor. And that's what I was showing before. And when we say quality, I'm not referring to the likelihood of it developing into a healthy pregnancy or anything like that. We can't predict those types of things. But what we can predict is what are the likelihoods of these eggs turning into embryos that are going to be genetically balanced or imbalanced. And age is certainly the best predictor of that. And age is really the best predictor of fertility overall. So this is the antral follicle count. So just to orient you a little bit, this is a side view, and then this is a cross view of the ovary. And I kind of describe the ovary as like a flattened chocolate chip cookie, where the little chocolate chips are these little circles that we can measure and count. And the reason why this is important is because we actually, when we're doing egg freezing or IVF, we're using higher levels of the hormones that the body is typically exposed to in order to allow for more of these eggs to grow instead of just one egg each month. So when somebody does egg freezing or somebody does IVF, we're not taking away eggs from the future that you would produce potentially in months to come. These are actually the eggs that would otherwise be dissolving off and not growing, where just the one egg is designed to grow to prevent multiple pregnancies from happening. So this is a little bit more of an overview of anti-Müllerian hormone. So one of the benefits of anti-Müllerian hormone is that it doesn't fluctuate throughout the cycle. And so you can look at an anti-Müllerian hormone at different times within the cycle, and it's pretty consistent. And it's generally not going to be impacted as dramatically by hormones as some of the other traditional egg supply tests that people would use. And so anti-Müllerian hormone tends to be the most helpful. However, folks who are on birth control pills for extended periods of times, usually years and years, it can sometimes falsely lower this hormone. And in those scenarios, we do consider stopping the pills temporarily if that's possible, using alternative forms of contraception and rechecking this anti-Müllerian hormone. And oftentimes it will rise up again, implying that it really was just the temporary suppression from those hormones. And anti-Müllerian hormone does correlate with age because, as I said, the number of follicles and eggs within the ovaries do decline with age. A really key message about this is that ovarian reserve tests do not predict fertility. And this was a really well-designed study that was published back in 2017, where they looked at patients who had low AMH levels, normal AMH levels, or really high AMH levels. And then they looked at those patients over the course of a year to see whether or not they got pregnant when they were just trying on their own. They had no history of infertility or anything like that. And what they found was that all of the groups had very similar chances of eventually getting pregnant within that span of a year. And so the hormone, the anti-Müllerian hormone, even if it's low, which we sometimes uncover, especially when patients are doing egg freezing, um, all it really tells us is how the ovaries will respond to the treatments. Do we expect that you will get lots of eggs in the process, a normal amount of eggs, or a low amount of eggs? It does not predict fertility. Plenty of people with low egg supply numbers can easily get pregnant. So that's a really common misconception, is that these tests predict fertility. And so, just while we're on the subject of fertility, some things that we talk about with respect to maximizing one's fertility. if you're not trying to get pregnant, then you should be using contraception that's reliable for you. So that's one consideration. As far as maximizing fertility, you can also think about the things that you want to do to optimize your health because we want you to be healthy going into trying to get pregnant. And so usually these things equate to healthy lifestyles. So not extremes of exercise, extremes of diets. Those things can sometimes influence how eggs grow and the function of those eggs. And so adequate nutrition, maintaining a healthy exercise routine and BMI or body mass index, and working on ways to try and manage stress, which is oftentimes easier said than done, but something that can be helpful. Also, knowing your family history. So, some things about family history can be predictive. So, the age that somebody goes through menopause can be predictive of their children's risk for going through menopause early, for instance. So that's important to know is your family's history if you do know that information. And then also considering things like family planning, like deciding, early on, do I want to have children? How many children do I think I want? And how can you best work that out? Like maybe you're not ready at this point, but what types of things can you consider, like egg freezing, which is what we're going to be discussing today. But egg freezing is one of the things that you can consider as a way to help with planning your future family. So let's discuss the egg freezing process. And so we do actually freeze them. So this image shows eggs after they're collected, and then this image shows embryos. And so vitrification is a fancy term for the process that we freeze the eggs. And we use a process called vitrification, which is a faster way of freezing eggs that has resulted in dramatically improved success rates, particularly from the standpoint of survival. Because when an egg is frozen and then it's thawed, that is a stressful process. And so, any ways that we can reduce the stress of that process, one of those is using vitrification, which is a more rapid method to freeze and thaw the eggs or embryos. And that has resulted in higher rates of embryos and eggs being able to maintain that process. So, just to give you a broad overview of what the process looks like for our patients. So, generally, you would meet with a physician and we would discuss your history. And as a result of your history, we're not only discussing like, is egg freezing a safe procedure for you? Do you have any medical or surgical contraindications for doing this procedure, but we're also assessing your overall risk for any fertility issues down the road. Occasionally, patients bring up scenarios like they've had surgery to remove an ovary or surgery to remove a fallopian tube. And we'll talk about what those implications for their fertility in the future might be, even though that's not their plan now to get pregnant. Maybe they want to just know sort of what type of scenario they may experience in the future. As a result of that screening and getting a really thorough history, we order any additional testing that is then coordinated by our coordinators. So each doctor has an assigned coordinator that is sort of your go-to person that helps to coordinate the testing. And we included in that testing would be an egg supply test, so the blood test for anti-Müllerian hormone, along with the ultrasound for an antral follicle count. And usually that's going to be performed with your doctor that you met for your initial consult. Next, when you're actually ready to proceed, we would set you up for a baseline ultrasound, and that is to assess whether the ovaries are actually ready to proceed with starting the medications to grow the eggs. The next point would be fertility medications, and we go through that whole process with you, and I'll kind of delve into that a little bit tonight. And during the process, we want to monitor with frequent ultrasounds and blood tests to evaluate how are the eggs growing. And so the way that we can assess for whether the eggs are growing well and how many eggs are growing and whether they're mature, we can do ultrasounds to actually measure the follicles, which are the little circles that show up in the ovaries. And as you have subsequent ultrasounds, you'll see that they physically are growing. And we want them to reach a certain size criteria before we think that they're mature and have eggs that would be able to be collected. We also do blood tests to evaluate for hormone levels to assess how those eggs are growing as well, because they should be releasing a certain level of hormone that suggests whether they're mature or they're growing and responding to the medications. Once there's a nice cohort of eggs that are growing and ready to be collected, we give one final injection that would cause your body to ovulate or release the eggs. And that's necessary to allow them to become mature eggs because immature eggs are not able to be fertilized or frozen at this point. So, giving that last injection causes the eggs to become mature, and then we perform an egg retrieval right before the eggs would be released. So this is all very carefully timed. And so there's definitely a lot of preparation that goes into this process to ensure that the timing is right. And so typically people will have their procedure 36 hours exactly after that last injection. That's an egg retrieval procedure, and I'll discuss a little bit more about what how we do that procedure. So there's two types of medications that we're taking, and goals with those medications. One is that then the primary goal is to take two hormones that are what one's brain releases from the over or from the brain, from the pituitary gland in the brain that signals to the ovaries and says to grow eggs. However, we're giving slightly higher doses of those hormones than would typically be released. And what that does is it allows for multiple eggs to grow in addition to just having the eggs grow themselves. So we're collecting a cohort of eggs that are starting to grow now. One of the risks of this whole process is that once an egg is growing, it could stimulate the brain to say this egg is ready to be released and ovulated. And so we actually give a medication that stops the brain from ovulating or releasing those eggs so that we can allow the smaller eggs to try and grow to catch up. And so that whole process is really important to monitor for these types of signs of ovulation. So we're frequently evaluating for that. The medications themselves, unfortunately, are not well absorbed by taking them orally. And so they have to be administered through injections. And usually patients are going to be using a fine needle similar to an insulin syringe. And it's a subcutaneous injection, meaning that it's only being injected really into the outer layers of the skin and the tissue right below it. So you're not injecting like a really sharp, like deep needle that's really long, like deep into your abdomen. It's really just on the outer layers of your abdomen. And that medicine then gets absorbed into the bloodstream and then functions in the ovaries. We do provide injection classes to teach all of our patients about the medications, how to inject them, and then we always have somebody available to field questions 24/7 when patients are having issues with any injections. But most patients catch on very quickly to the process. And these medications that one takes are typically taken for about 9 to 12 days, here 10 days on average. And during that time, you're also presenting for ultrasounds and blood work, like I mentioned previously. Usually, on average, it's about 4 ultrasounds during that time. So this shows the process of egg retrieval. So back in the older days, we actually had to do surgery to go in and remove these and place cameras into the abdomen, or actually take the ovaries out themselves and then remove the follicles. Until we found that the best way to actually perform this procedure was without any incisions at all. So we use an ultrasound that's placed vaginally, and the closest distance to the ovaries is actually through the vagina. And so this shows sort of the location of the ovary here, and this is the ultrasound probe. So the probe is right next to the actual ovary. And we're able to guide a needle through the skin of the vagina directly into the ovary. And drain the fluid. So this is what a follicle looks like when it's larger, and that fluid pocket is then drained. So I have a video here. I'm hoping it will work. There we go. So here the needle is then advanced into a follicle, and then you'll see soon the follicle will start to collapse. So that black fluid is being aspirated into the needle, and the follicle will collapse here. What happens next is that that fluid is collected into a tube, and that tube is then provided to the embryologist, who's a specialized lab personnel who looks through that fluid and looks to see, is there an egg in that fluid. So healthy eggs equal healthy embryos. So that's a key component, and why it tends to be better to freeze your eggs when we think that the eggs are going to be healthier. Because, and by healthy, I'm mostly referring to the genetics and the likelihood of having those imbalances. There's a lot of prediction that's happening here because we're freezing eggs with the knowledge that the better these eggs, quote unquote, will be, the more likely that they will turn into an embryo when you actually go to use them. But there is a little bit of uncertainty in that process because we don't know how the eggs actually will respond. And most of what we're doing is predicting based off of how other people have done when they've gone to freeze eggs. So let's talk about the success rates. And I actually wanted to provide a resource that I think is valuable. There's this BWH egg freezing calculator where you can go in and actually put in the number of eggs that you freeze and your age when you froze them. And it used all of this data looking at the probability of a pregnancy, a single child having two pregnancies, not at the same time, but like two separate pregnancies or three children. And this shows the success rates based off of when the eggs were frozen. So at the age of 30 to 34, the success rates are much higher, up to 90% here, based on having 30 eggs frozen. And then those rates do go down a little bit as one ages. So 35 to 37, 38 to 40, these rates go up to like 70%. So we're guesstimating based off of studies where they've evaluated people who have gone and frozen their eggs, and we have our own data from our clinic as well for patients who have done this. And so that's where we get the numbers that we use. On average, for people who are less than 35, we recommend freezing about 15 to 20 eggs per desired child. That gives you up to an 85% chance of a live birth. And for people who are over the age of 35, we generally recommend freezing 25 to 30 eggs on average. And when we've looked to see at outcomes of pregnancies, when you use fresh eggs, meaning that somebody goes and does IVF versus somebody collected eggs, froze their eggs, thawed those eggs, and then used them for IVF, there's no differences in the pregnancy rates, and there's no differences in the pregnancies themselves, like how people delivered or the complications within pregnancy or the actual neonatal or effects on the actual babies themselves. So no difference in delivery or the neonatal outcomes. And we've had over 300 babies that have been born from vitrified or frozen eggs here at PFC because PFC has been one of the pioneers in the egg freezing process, having been around since this was even invented. This shows the success rates, or sorry, the euploid rates by age, which I showed this previously from a published paper. This is using our data from PFC. So again, this is the likelihood of euploid. So it's looking from the opposite perspective. Before it showed aneuploid or imbalanced embryos, but the percentage of balanced embryos reduces as you get older. Okay, and that's part of the normal aging process. When people actually go to use their embryos, we kind of pride ourselves on single embryo transfer, meaning that you're only transferring one embryo at a time. And that's been really helpful in lowering sort of the risk of multiple pregnancies or twins or triplets that were traditionally really associated with a lot of fertility treatments because people were transferring multiple embryos at a time. But we have very high success rates where we don't need to transfer more than one embryo. And we find that when you do transfer more than one embryo, it doesn't increase success rates. All it does is increase the likelihood of more than one embryo implanting. And so our goal is one healthy baby at a time. And looking at the process, so yes, you froze your eggs. Now, what would you be thinking about in the future if you actually decide to use your eggs? We would warm those eggs or thaw the eggs. We would then inseminate them with sperm, which is a process called ICSI, where we actually inject the sperm into the eggs to help them fertilize. You may or may not opt to do genetic screening on the embryos. And when I say genetic screening, I'm mostly referring to looking at the balanced or imbalanced genetics that I've been kind of referring to this whole time. And then once you have embryos, you can transfer those embryos or place them into the uterus when you're trying to get pregnant. So just to give a little bit of a background of PFC has, or Pacific Fertility Center, we've been here since the 90s. I have not been here since the 90s, but I have had the pleasure of working with folks who have been and learned a lot about the clinic and the process. We've been freezing eggs here since 2006, and back then this it was actually considered experimental until there was a lot of safety data that showed that it was safe to do this, and subsequently switched to being approved by the FDA. And so we were on the front lines of this process and making this a reality, especially in the Bay Area, where we have a lot of patients who, even in the 90s and early 2000s, were prioritizing work over and their careers over being able to build a family. And so it just gave patients that flexibility to be able to plan their families a little bit better. And so, just to give you a little bit of details, like if you want to move forward and you're interested in a consultation, Stephen already mentioned that there is a nice benefit of attending this webinar for doing a consult with one of our physicians, myself, or one of our other three physicians. And so, if you're interested, you can reach out via email or also to this phone number. And at the time of your consult, we would discuss all of these different options and also assess your potential future fertility. We have two locations currently. One of those, our main location is in San Francisco, right in the heart of the city. And we have another location in Marin as well, in Greenbrae. And I'd like to open the floor to questions. You can follow us on Instagram, or maybe you found us through Instagram, but um, we have some really fun posts that are coming soon. So hopefully you can stay tuned for those. And I'd be happy to take any questions.
Okay, well, if any of you have any questions following this, you're welcome to email us at info@pacificfertility.com. You're also welcome to give us a call and register as a new patient if you'd like. Um, we first of all just want to thank you for being here tonight, and we hope that you found the presentation informative and helpful, figuring out your journey, your personal journey. We will also be sending out a recording of the webinar tomorrow, so keep an eye out for that. If you have any follow-up questions, feel free to respond to the email if you'd like. You can also call the clinic at 415-834-3095. And we want to thank you again for joining us this evening, and we hope that you have a great rest of your night.
So it looks like we do have a question here, a couple questions. So I'd like to answer those.
Yeah.
So first question is what is the length of time that it takes to actually freeze eggs? And typically, I mentioned that you're on the medications for about 10, on average, about 10 days. and then we add on a couple days of the actual like before your egg retrieval. And so it's usually about 2 weeks active that you are spending in this process. But it's over the course of a month because some people take medications leading up to this process. So on average, it's about a month, but the active portion is about 2 weeks. And another question is we didn't really talk about much about like freezing eggs versus freezing embryos. So there's a question about whether you should consider freezing eggs versus freezing embryos. And so the main consideration with embryos is that there's a few advantages there. One, if you have a current serious partner or a sperm producer that you would consider freezing embryos, you can get a little more information because remember that not all of the eggs um, are going to grow into an embryo, and a certain percentage of those eggs will result in an embryo. And so if you go through the process of making embryos, you see what that drop off looks like and you know what you have. You have this many embryos, and actually embryos, because they've gone through that drop off, we can give a little bit more of a prediction regarding the likelihood of a pregnancy from an embryo. It's about 50 to 55% live birth rate per embryo versus eggs have about a 5 to 10% because they have to go through that whole drop off. The other advantage of embryos is that we can do the genetic testing that I mentioned. At this time, there are no genetic tests we can do for eggs. The disadvantage of embryos is flexibility. So, ultimate flexibility with eggs because unfortunately, we can't unfertilize an embryo. So if you make embryos with a sperm producing partner and you are no longer with that person in the future, when you want to use those embryos, you may have regretted freezing embryos at that time. So some people will choose to even freeze some of both. There's a lot of flexibility, and that's why we spend time discussing with you your goals. And the last thing, there's a question, how painful is it to get ovarian stimulation injections, with 10 being the most painful? I can't speak from personal experience because unfortunately I cannot freeze eggs myself. But I will say that people have described all different ranges. Most people say that the injections themselves, like giving yourself the injection, is not very painful. Like it's kind of like getting even less painful than a bee sting, for instance. And the actual process itself at its most painful would be probably right after the procedure. Your ovaries are enlarged. You can feel that the physical weight of them, and there's some bloating that typically is expected. But even that is like probably a 2 out of 10. So there's always going to be exceptions. Circumstances can change. I'm not going to say that there's no likelihood that things could be more painful, but I'd say 95% of the time, people typically do very well and don't describe pain as a real consideration. Okay, so I think we've answered all the questions. If there's no more, then we will let you all go on with your nights.
All right.
Uh,
Everyone have a great night.
Thank you. Bye.
Bye-bye.